This presentation will examine the geographic factors pertaining to prevention versus treatment of HIV/AIDS in South Africa. HIV stands for Human Immunodeficiency Virus, which infects cells of the immune system by destroying or impairing their function. The virus attacks and destroys the cells which are needed in order to fight against infections and diseases in the body. The most advanced stages of HIV infection is known as AIDS, or acquired immunodeficiency syndrome. People with AIDS will have to take medical intervention and treatment to prevent death. The main difference between treatment and prevention is that treatment are for diseases that someone already has, whereas prevention is avoiding that disease in the first place. In the case of HIV/AIDS, it is obvious that prevention methods are much more beneficial for a population, simply because HIV/AIDS is still an incurable terminal disease and treatment would only allow a patient to prolong their life. In Figure 1, it can be seen that in the years 1990 to 2005, the African population is responsible for more than 50% of the world's HIV/AIDS affected population. The graph shows that the number of people acquiring HIV/AIDS increased the most between 1994 to 1999, and in Africa the number has slowly started to plateau from the year 2000 onwards. Figure 2 shows a rapid growth in the number of people who are infected with HIV in South Africa between the years 1990 to 1998. The graph also highlights the fact that between 1996 and 1997, South Africa experienced a slower growth from 14.1% to only 16.0%, in comparison to the trend between 1990 to 1995 that shows exponential growth. However, it also sharply increased to 22.8% from 1997 to 1998. It can be seen that the higher prevalence of AIDS in the population are located in the upper northwest of South Africa, ranging from percentages such as 23% all the way to 32.5%. The two lowest prevalence of AIDS is in the North Cape and Western Cape at 11.4% to 7.1% respectively. Another interesting trend to note is how the populations in the northwestern point of South Africa is predominantly that of a black population, while that of the two lowest, North Cape and Western Cape, there is a significant population of white South Africans, suggesting that AIDS is more common in the black population of South Africa rather than the white population. There are several cultural factors that affected the use of prevention and treatment for the South African citizens. Firstly, at the time of the epidemic outbreak, South Africa was in the midst of racial conflicts of apartheid, which caused the HIV problem to be largely ignored. While political unrest dominated the media, HIV/AIDS prevailed, thus both prevention and treatment were out of the question. Crucial time was lost in the fight against AIDS as the government was distracted with more immediate concerns such as regaining political stability. The apartheid regime and the resulting consequences such as gender inequality and the migrant labor system, in which laborers were not allowed to settle in urban areas where they worked, would move between work and home frequently, were major factors in the spread of HIV. Stigmas of the South African community are a major barrier for people to access treatment and prevention facilities of HIV/AIDS. As the outbreak of the epidemic was initially denied from existence by the government, the public's opinion and awareness were affected by outlets such as state-run media, who avoided talking about the subject altogether. This influenced the awareness of the problem and allowed HIV/AIDS to spread dramatically. Due to the general stigma from HIV/AIDS, those who were tested to be HIV positive are hesitant to seek treatment or support for fear of being discriminated by others. People are also reluctant to disclose their HIV status to others, so many are not willing to get tested, in fear of being found out by the community and being ashamed of having the disease. Because of this, more emphasis has been placed upon the prevention of HIV/AIDS rather than the treatment of it. Although South Africa is one of the first countries to strongly discourage discrimination on the basis of sexual orientation, being promotive of equality and gay rights, homophobia is a common social stigma, and this topic is often avoided being taboo in the culture. In the early developments of HIV/AIDS, it was first thought to be a homosexual disease. Therefore, prevention or even treatment was rarely talked about, and awareness was minimal. Although this way of thinking has been less common, the stigma still exists, and many of those in the homosexual community still hide their sexuality and not access information that could protect them against HIV infection. Lastly, South African culture is generally male-dominated, with women in a lower status than men are. The resulting unequal power relation between men and women increases women's vulnerability to HIV infection and accelerates the epidemic. Violence against women is a major problem in South Africa, resulting from the male-dominated culture. Women who fear or experience violence lack the power to ask or speak up against their partners to put on a condom for protected sex, thus unable to prevent HIV transmission. Furthermore, gender-related barriers in access to services can prevent women and men from accessing HIV prevention treatment and care. For example, women may face barriers due to their lack of access to and control over resources and childcare responsibilities. For men, they may not use HIV prevention products due to the fact that they do not want to be discriminated against or lose their jobs by being perceived as weak or unmanly because of their socialization and gender norms. There were AIDS deniers in the government. In fact, in one MDG summit, the South African representative, Manto Msimang, tried to convince the panels that beetroot and garlic was able to cure or treat AIDS. During the rule of Thabo Mbeki from 1999 to 2008, as much as 330,000 had died due to AIDS and not receiving treatment, as outlined by one Harvard University study. Under international pressure, South Africa did eventually launch a national program for the prevention of mother-to-child transmission in August 2003 and a national adult treatment program in 2004 under Thabo Mbeki's rule. But by 2005, the paper's authors estimate there was still only 23% drug coverage and less than 30% prevention of mother-to-child transmission. Another reason given for AIDS not being considered a priority in the government or political system was that many other matters needed addressing. The government, it has been suggested, preferred to focus on policy areas that symbolize optimism for the future. This is summarized in a statement by Van der Vliet, who said, "It was also a time when the new government would prioritize positive programs such as housing, jobs, education, and wider healthcare issues. AIDS warnings and the messages of safer sex were not subjects congenial to those savoring the euphoria of freedom." Instead of putting it in the presidential office, the problem of AIDS was given to the Ministry of Health, suggesting a lesser priority towards the improvement of AIDS situation. Furthermore, people were not taught about HIV and its role in AIDS. However, there have been campaigns such as Love Life, Soul City, and Soul Buddies, each one with a large backing of money, as much as $13 billion and has run since 1999. However, these were not government-backed initiatives. These campaigns have been largely successful on the target demographic of 15 to 24-year-olds. However, they still do not understand how contraceptives work in preventing the transmission of HIV/AIDS, evidence of lack of education in schools. Zuma replaced Mbeki in 2008, which shifted the focus on prevention rather than treatment, launching HIV testing and counseling campaigns. Those who received counseling and testing also received 100 condoms. The campaign also involved other prevention initiatives such as education, information, and mass mobilization. The government focused on prevention rather than treatment as it was cheaper due to the fact that prevention could be as simple as putting on a condom. Prevention is usually short-term while treatment is long-term due to the way diseases work. Also, the Medicines Control Council refused to allow continuing research on Viridine, a type of ARV which not only wasted time and money but also increased reliance on prevention medicines. Treatment also costed too much money. The ARV costs $271 per person per month, yet there are 5.6 million people living with AIDS, and the average wage is $275. Therefore, the government would have to shoulder an immense cost for treatment through ARVs through reallocating government funds from other problems. From what can be seen, for the most part of the trend of HIV/AIDS from 1990 to 2008 in South Africa, policymakers have not been focusing on the treatment of AIDS. Thabo Mbeki and his appointed Minister of Health during their power were AIDS denialists. As a direct result of this, the general public did not understand how prevention worked because they were not taught how HIV caused AIDS. Furthermore, the overall stigma of HIV/AIDS in South Africa discourages citizens to find out about their HIV status, making it difficult to provide treatment to those who are unaware of their own status. Therefore, more emphasis is placed on prevention rather than treatment to protect a larger proportion of the population. Additionally, the male-dominated society in South Africa means that women cannot prevent themselves from HIV infections due to their inability to speak up against men. Finally, from an economic point of view, the South African government focused on prevention rather than treatment because the government not only did not have enough money to pay for an epidemic, but also because there were no other acceptable solutions to the problem at that time.